Good morning.
Good morning.
Hey, good morning. All right. Good morning. Yeah. Like a teacher, right? Or a preacher. Good morning. My name is Ann Reed. I am a pediatric rheumatologist at Duke University. I've been part of this community for a long time. Because of how the delays that we've had, they've asked us each to condense what we're talking about into 10 minutes, all the follow-up speakers, me and the others. So I'm going to move forward, and if you have questions, we're always happy to answer them. I want to just start out, before I even start talking about old therapies. I was asked to talk about old therapies and what do we know now about them. I wanted to give you just a little history. Forever, we've always felt like treatment of dermatomyositis in children really came into multiple buckets. That over 50 years ago, or actually before the 1950s, about a third of the children did really poorly and passed away. About a third of the children had horrible disability, and about a third did well with some minimal disabilities. And this was before the onset of steroids. And then once steroids really hit, it changed the world. It changed it so that we now could get majority of children did well in terms of function, being able to do things, yet we now are in the era of having side effects of steroids, and long-term side effects, as many of you know, can be pretty significant. And that kind of takes us to what we call the present time, where we've really been trying to focus on how do we maximize and improve the types of treatment that we do use, minimizing things that we know have side effects, even though are incredibly beneficial and helpful. And that's sort of where we are today. And so if you see this list, these are all the medications that we routinely would use or could use in a patient with juvenile myositis. And if you look in this red box that I have outlined, and you look at the evidence behind using these medicines, for us in medicine, the field of medicine, is very little evidence. Many of them are just cases. You say, well, I had 5 children and they did well. And this is really where we were until more recent times. And we've really been trying to now say, how do we get more evidence behind what we do? How do we know whether you need IV steroids or just oral? How do we know that you need them for a short time or a long time? We need to get that information out. What we've done is what we historically have known is to be the right thing, and historically all the patients that we've treated, we said this is what we believe is the best, but we've been trying to gain more and more of that information. And so this came, really, a lot of this work started with CARRA, who's the Childhood Arthritis and Research Alliance. And this is really a group of pediatric rheumatologists and healthcare providers that came together that said, we want to advance the way we treat children with autoimmune diseases. And this group came together and really formed what we called a registry. We call it the Legacy Registry. And it has over 800 patients that were really enrolled in this registry. The idea was, could we get information and be able to share it and look at what the best treatments would be. This group also developed something called consensus treatment guidelines, and I'm going to share those in more detail with you. And they've also been conducting studies such as looking at children with myositis and trying to say, can I look between these different treatments and actually say that one seems to be better than another? And so why are we doing this? Well, this is a graph that really shows, or a figure I should say, that shows you based on what was determined as cases of myositis, whether the case was mild, moderate, really severe, if a child had ulcers, the variations, the color shows you the variations in how the experts were treating the patients. And so even though we all feel like we're on the same page, I think over the years we were educated differently, we had different experiences, and so there was huge variations. And so how can we then go and compare people's information if there's such variations in how we treat? And not just the kinds of medicines, but this is showing you a graph, showing you variations in how we even use steroids. So this really made us as a community say many years ago, we need to come together and really define what we think are appropriate treatments for people to use the majority of the time. And the beauty of what was developed, and these are the 4 articles I'm going to highlight, I'm going to go into some details, is that really it was to say the treating physician uses their best judgment to say what's the right thing for the child. And if the physician feels that they need something different, they need to change things a little bit, that's totally within their realm. But what it does is it takes us down from having hundreds and hundreds of variables that we can't compare very well to having just a few variations that we could compare directly, again, to say what is the right thing that we should be comparing. And so if I look at the initial treatment that was recommended, consensus protocol that was published, there were actually 3 different protocols within that. And these were for the majority of children with pretty moderate to severe disease. And the 3 protocols really stem from a basis, which was methotrexate and prednisone, or a form of steroid, but prednisone was the one that was most commonly used. And this was oral prednisone. It was not using any types of injectable or IV medication. The second protocol was adding to that IV steroids, IV methylprednisolone, many of you are familiar with. And the third protocol added to that IVIG. Sorry, it must have fallen off the slide, but it was on here, to the protocol. And so now we have 3 things that are recommended that we believe that most patients could go on, and then we're able to, through this CARRA network, collect the information on how a child's doing, what kind of side effects the child's having, and so it allows us to kind of do a clinical trial without needing $20 million to do a clinical trial, because now we can collect the information and make suggestions. And the first set of information, actually, you all actually supported us collecting on a small group of patients, looking at differences in these 3 treatments. And we actually have some of that initial information right now. It's not 100% analyzed, but at least the preliminary, we're not seeing a lot of differences between the groups, between these 3 treatment groups. But more information is needed, and we need to do more studying, and actually we need to study more patients. This was a very limited amount of patients that we studied. We also were collecting biological samples on patients so that we could actually look at the biology behind who responded or who didn't. So for some reason, if somebody didn't respond and they needed to go on to other medicines, what is it in their biology that we could maybe get some information to understand better? Another one of these, oops, sorry. There you go. That's what I was going to show you in larger font. The second treatment pathways that have been published is children who start out with disease, but their skin just won't go away. This happens to many individuals where it just seems like their skin is very persistent. There were also 3 different pathways that were recommended, and this is in addition to the baseline therapies, the steroids, the methotrexate, potentially IVIG that a patient's already on. And for these 3 different pathways, the first one was just adding IVIG if you didn't have it already on board. The second was potentially using mycophenolate mofetil, which is Cellcept. And the third is using either cyclosporin or tacrolimus to add to this therapy, thought to be helpful and have adjunct, so it's additional therapy to help improve the skin disease. And the third one that came about was saying, what about if your child only had skin disease when they presented? They really never had muscle disease. And so, again, there were 3 treatments that were recommended in addition to what everyone should be doing, which is skin protection all the time, every patient with myositis, but came up with now 3 treatment recommendations for this. One is hydroxychloroquine, which is also called Plaquenil. One is Plaquenil with methotrexate, and the third is adding prednisone to that regimen. So by us now narrowing down and having fewer variations in treatment, we're hopefully going to be able to use more and more of this information to guide you all on what decisions that we need to help you make around treatment for yourself or your child. Another study I want to mention, and there's a lot of bars, so I'm just going to go in general. This was a big international trial that was spearheaded from Europe. And basically the trial was to say, let me compare the outcomes in patients who've used just prednisone and cyclosporin, or prednisone and methotrexate. And what the take-home message is that in the blue and the green, yep, shows up blue and green there, bars, and each one of these different sections talks about the level of improvement, 20% improved, 50%, 70%, and 90%. But overall, the pattern is when you use steroid with something else, the improvement is much higher and much greater than if you use steroids by itself, which used to be the old regimen that sometimes people still use, but most often they add something. I think the bigger take-home message that I also want to say is we don't use as much cyclosporin in the US as they do in Europe, and some of it has to do with availability of medicines. But when they compared side effects, they found that methotrexate had much less side effects than cyclosporin. So this kind of confirms what I showed you before with those treatment protocols. It kind of validates the fact that we think we're in the right place in terms of what combinations and what medicines we should be looking at. Another thing I want to highlight is another group, the International Myositis Group. This is made up of all kinds of specialists that came together to help improve our outcomes by giving us some more standards around what does it mean to improve? What does it mean when someone's better? My my saying someone's better may be different than Lisa Ryder's saying something better, but how do we do it? How do we speak the same language and all be on the same page? So this group really came together to help us standardize this and say, when we're collecting information, how do we know someone's better? This is the measurement. They're 20% better here. They're 50% better in another of our measurements. And this coming together to develop these outcomes really then stemmed this rituximab and myositis trial. When we were able to start planning for this and receive money from NIH to start planning, it was with the understanding that our main focus was to improve the way we measure outcomes. So one of the second focuses is then to do a clinical trial and test these outcomes. And I think overall that we were very lucky because rituximab, it's a newer of the old drugs. I mean, we've been using it for a while, and there's many different studies, this being probably the largest and the most controlled, and that 83% of patients got better. And let me just walk you through this plot. This is actually showing you, as you go down, people are getting better, and on the bottom it tells you how long did it take them to get better. And so 83% of patients got better, no matter if they got treatment early or late, they all got better. But when we subdivided patients into whether they were pediatric patients or adults, the pediatric patients got better faster. And then we look at different antibodies. So we've talked a lot about myositis antibodies over the years, and when you look at it, there's some, such as in the black and the red lines, that got better a lot faster than maybe the person in the blue line, suggesting that if you need it and somebody's sick and you want someone to get better in a month or two, maybe these antibody groups will help us actually predict or determine who maybe is going to get better quicker versus somebody who has a different antibody status that might take a half a year or longer to get better. And so, again, gaining more information on how to use these medicines, which can be fabulous when you need them, but we don't want everyone to have them, and we want to use them in the right people. We want to make sure we're predicting who really needs these medicines. They're expensive, they have side effects, and we don't want kids having to go through things that maybe they don't need to. What about a couple other old things? One is IVIG. We've used IVIG for a long time, and we have information to suggest when you add it to what you're doing, people can continue to get better. This study actually looked more at the sustainability and compared it with groups that got IVIG and didn't, directly compared it. And basically the take-home message on this study as well that showed that IVIG really benefited improvement of disease in the first few months, and it was sustained. They actually looked years later and said, if you got IVIG, you seem to have been doing better when we even looked years later. So it could have some long-lasting effects as well. Also looking at steroids, this is always a big question. We all believe very strongly steroids are necessary, but it's how much and how long. And this was a study really looking at using really high-dose aggressive IV steroids versus a lower dose or 2 per kilo orally. And what they found is that there was improvement using the higher aggressive in some of the muscle enzymes, but what was not clear was that there really weren't differences in some of the measures we use to say, is your skin better or your muscles better? Now, saying this actually leads to the next sort of item, which is there's more to the story with everything. Often when we choose therapies, we choose them because we think patients maybe have more severe disease. And so you might be biasing the study to more severe patients are in the group that's getting high, the IV doses versus not. And so this is where a lot of the work right now that's going on, it's like modeling the data we have and looking at all these different components of data to come together and say, can we really tell who's going to benefit and who needs this? Does everybody need IV steroids or maybe not? And those CARRA treatment protocols I told you really will help us get to some of the bottom of this. The other is looking at some CARRA data. We found that if patients were treated with hydroxychloroquine, again, Plaquenil, they felt that when that happened, they were much more likely to feel better. The patients felt better and reported feeling better, and the parents felt like their child was doing better as well. And so, one last study that I want to mention, and this is a study on cyclophosphamide or Cytoxan. This recently was published, and it's a drug we've used for a long time for people with pretty severe disease. So we don't use it often, and we don't like exposing children to this unless it's necessary. But what this study really showed is when they had patients who were treated, this is showing you a disease activity score, a physician global assessment, like how does the physician think someone's doing, And as the bars and the lines go down over time, it tells you that there's been significant improvement. And this is going back to, again, an old drug that's been used in a few cases here and there to treat lung disease and ulcers. But this is now showing us in a larger study saying, yeah, this medication can absolutely work. It doesn't mean it's for everybody by any means, but it's actually showing us in this controlled study that it actually is doing something. So I'm going to end there, and no questions, but I want to thank you for your attention, and because nothing matters more. Thank you.